Okay. Well, we're here today with Dr. Jeffrey Humbarger, and we're going to continue our Integrity in Healthcare series on our YouTube channel. And so, Dr. Humbarger, I want to thank you for being with us for
You're
this
welcome.
interview. And to start off, I just wanted to see if you would tell us a little bit about your medical journey, whether it's where you started with med school, any hospitals you've been at, or specialty clinics, and what led you then, now you're here at First Physicians Group in Sarasota, Florida.
Gosh, it's been a long journey, many years. I went to medical school at University of Cincinnati, graduated in 1982, did a residency in Santa Barbara, California,
Okay.
and then practiced at a community clinic and then at a private practice clinic in San Diego for a while before moving to Mayo Clinic in Jacksonville, Florida. After 15 years there, I got restless and have been in Southwest Florida since then.
Okay. And so what I wanted to talk about is kind of a couple things. One about rehospitalizations and also the differences between primary care and geriatric care. And so what I wanted to start off with is asking you, is there a difference in care philosophy between a geriatrician and say a primary care doctor that my family might go see?
Well, there really shouldn't be,
Okay.
but not everybody who's a primary care doctor has a training or experience in geriatrics, and if you're spending a lot of your career or your time, seeing kids and young adults, then you may not have the time frames in your office set up to see complicated geriatrics patients.
Okay.
So,
Do you think there's a certain age or maybe a specific health condition that a patient might start considering transitioning from their family doctor that they've been going to for years, from maybe teenage years to adult years, to their senior years?
well, I don't think it's a specific age. I think it's more of conditions.
Okay.
The things that lead people to need to go to see someone who either specializes in geriatrics or knows a lot about a geriatric medicine is, frailty, multiple medications and multiple medical problems, rehospitalization.
Yeah, which we're going to get into. Yeah.
Mental problems like, getting dementia, getting forgetful,
Yeah.
those type of things. In geriatrics, we talk about the eye syndromes.
Okay.
I have a list of them here. 13 eyes.
Okay.
Immobility, instability, incontinence, intellectual impairment, which is either depression or dementia or delirium, infections, vision and hearing impairment, irritable bowels, inanition, which means malnutrition,
Okay.
iatrogenesis, which means that the medical community is causing harm to one,
Okay.
insomnia, immune deficiency, and impotence and female sexual dysfunction.
Okay.
So 13 different
13 different,
eyes.
and we're
yes.
probably going to get into some of those.
Possibly, yes.
So one thing you mentioned rehospitalizations, and I've been actively involved in a local coalition for the past year with the Florida Hospital Association, and our whole purpose in meeting with this coalition is to try to discuss ways to decrease rehospitalizations. And so do you think there's a common diagnosis, or what might be the most common diagnosis that leads to rehospitalization in older adults?
Congestive heart failure.
CHF.
That's the number one.
Is it? Okay. That's what you see mostly coming through your office too, and the hospital.
Yeah.
Okay. What does, and you mentioned this too, in one of the eyes, medication management. Does that lead to, if there's poor medication management, can that be a contributing factor to rehospitalization?
Oh, yeah.
Okay.
If
kind of the problem with
well, I mean, there's been a real big push in medicine for the past 15 years about medication reconciliation. When people move from one doctor to another, from a nursing home or a rehab to back to the primary doctor, or from the hospital, and knowing which medicines that they're on and everybody being on the same page. And if you're not, and the hospital puts you on one medicine and you're not taking it because you forgot to buy it, or you thought it was too expensive, and then suddenly you're back in the hospital because you're not taking the treatment that was prescribed there.
Yeah, so it's confusing enough then in the healthcare system. I know from skilled nursing and doing what I do now, you're exactly right. Like somebody comes from the hospital, maybe they took them off of medication there, and they go to rehab and they want to be put back on with a different doctor, and they go home. And so that's one thing. But
And then the rehab doctors decide that they need a different medication,
yeah,
and then they come back to me and I have the hospital record, but not the rehab hospital record.
okay.
It's just
So it's a kind of a
communication
yeah.
problem.
Okay.
Yeah.
Do you think that leads to a lot of confusion with but not just with seniors, but anybody, because they might not get the correct dosage or frequency.
That's correct.
They might
yes.
take too much or not take enough or forget to take it at all.
That's right.
Okay. Any because I know that's a big issue with communication, but any thoughts on what would make that better?
Well, the Health Information Exchange Network that was promised under the Affordable Care Act but never really came to fruition is now starting to be used more.
Okay.
Especially, the hospital has been really sending out HIE stuff recently. Okay. And if we could get the other hospital in town,
Get it to return.
or get what's the name of the rehab hospital over off of Clark Road?
Oh, on Rand Boulevard?
No, the one on Clark Road. Not Clark Road west, east of the 75. Encompass, yeah.
Yeah.
Get places like Encompass to give us HIE documents.
Yes.
Instead of guessing and having to call them up and saying, well, what's he on?
Yeah, exactly. Well, that's something that has been discussed in the local coalition as well. As we feel it's a communication breakdown, and some are doing it right and some are doing it well. They would like to have it, returned back in the same way.
Mm-hmm.
So, what chronic conditions are most likely, would you say, to lead to rehospitalizations in seniors?
Well, congestive heart failure, like I said, COPD.
Okay.
Chronic obstructive pulmonary disease.
Yeah.
People with kidney failure bounce in and out of the hospital all the time. People who are frail and with osteoporosis and they fall and they break something and they go to rehab, then they get a pneumonia or a UTI, urinary tract infection, then they're back in the hospital.
Okay.
Those type of things.
So just recurring.
Yeah. Complications of diabetes too is a big one. Either they're not getting their insulin right, or they're taking too much insulin or pills, and they're in with low blood sugar, high blood sugar.
Okay. Yeah, I do see that a lot in assisted living communities too. They're not doing that correctly. You mentioned something too in nutrition. What role does poor nutrition? The reason I asked this question, I remember going out and seeing my dad, before he passed away back in Kansas, and my mom was in a memory care community, and going to his house and opening up his refrigerator, there was just nothing there.
Yeah.
And what was there probably wasn't the best things to eat. So what do you see in seniors as they get older, maybe living alone? They're just poor nutrition habits.
Yeah, part of it is access to getting groceries.
Okay.
And then being able to prepare the groceries.
Yeah.
And then not throwing away things that get rotten and not being able to tell, and that makes you sick.
Yeah.
And as people age,
tastes
do change, yes.
Okay.
And as one ages, also the appetite changes along with the taste buds, and then you may not want to eat. You don't care to eat. Plus, you're on a bunch of different medications that upset your stomach.
Do you see that often in the hospital setting with people who have poor nutrition that come in?
Yes.
Or maybe it's a contributing factor?
It's a contributing factor, yeah. Because poor nutrition causes muscle mass loss, and if you don't have good muscle mass, then you don't have reserve, and it causes immune problems, so your immune system doesn't work as well.
Yeah, I just wish, the thing I saw in my dad's fridge was all sweets.
Well,
a lot of sweet food. Not the healthiest stuff.
That's because the taste buds for sweet are the ones that degenerate, and the ones for sour and bitter stay in your mouth. So you try to overdo the sweet intake to be able to get some decent tasting.
That makes sense. Okay.
Yeah.
So one question I want to ask you, because I know you do telehealth. It's been increasing over the last few years, and maybe because of affordability or simplicity. also technology and everything. Do you think telehealth has made an impact on the rate of rehospitalizations?
Oh, I mean, telehealth has done a lot. It helps people who are homebound and people who have difficult, they have to have a walker and a wheelchair and an attendant and all that to get into the office. It helps to be able to assess them at least somewhat that way.
Okay.
I don't know if it does
And how do you
prevent hospital. It may,
how would
but
they
I don't know if
set
that's
up
been studied.
a telehealth appointment with you? Do they call your office and it sets up? Or
Yeah, they
is
call the office and they say, do you want to be seen in the office or by telehealth?
Okay.
And if they're seen by telehealth, they're on the schedule as a telehealth, then we call them up and triage them, and then I talk to them on the phone or by video.
Are you seeing an increase just in your offices here with telehealth?
Well, it really increased during the COVID epidemic.
of course, yes,
So,
of course.
and it's still a remnant of that.
Yeah, and people are comfortable with that.
Yeah.
You found? Good, good. So one thing that I've noticed, and moving on to like screenings and testing and things like that, you drive down 41 and you see the different pharmacies, get your screening here, or vaccination here, and the hospital has signs too. What do you think are the most essential health screenings or exams that adults should prioritize, let's say, after the age of 60?
Well, if they're over 65, Medicare pays for an annual wellness visit, which is not really a medical physical thing, but is a screening for fall risk and memory and lack of access to let's say housing, food, those type of things are all screened for. Once a year with our actually ask our patients every visit if they've had a fall.
Yeah, and if they do have a fall, if that's part of their annual or their fall risk, can you just go ahead and maybe prescribe home health to go to their home and do therapy and things like that? Okay.
Yes. But as far as screening tests go, I mean, everybody should have a colonoscopy, even if you're 60 up until age 80. Everybody should, women should all have their mammograms, and men should have their prostates checked. You get the big three cancers. Should be screened for. Annual blood tests to make sure that, especially if you're on different medications, to make sure that they're not affecting your kidneys and liver or blood count.
That's a good point. Yes. How can early detection through routine exams, like you're saying, annual exams, and after 65, how can they improve maybe even the outcomes for older adults?
Well, I mean, early detection of cancer makes you live longer from that cancer.
Okay.
I saw a fellow this morning, 66 years old, thought he was healthy, and the nurse said, his heart rate's a little slow. So I go and examine him, and he tells me that, well, I've been feeling lightheaded occasionally. So I'm listening to his heart, and it's very slow. And I do an EKG, and he's in a really bad slow rhythm at 34 beats a minute.
Oh my gosh.
So he needs a pacemaker.
He needs a pacemaker.
Yeah.
Oh my God.
Found that at his annual wellness visit.
Oh my gosh.
Yeah.
Okay. So yeah, are there specific exams you think that people overlook that maybe they should do?
Well, a lot of people overlook their colonoscopies.
Okay.
50% of people eligible for colonoscopies get them in the United States, but there's also people who get the Cologuard and the Hemocults and that to check. So we're screening about 65 to 70% of people for colon cancer every year, which I think is not bad, but it could be better.
Could be better. Why? Let me ask you this. I've seen a lot of increase in the last few years, and especially in my role with going in and meeting with families and getting referrals from the hospital and going into the patient's room, and they have cognitive impairment, Alzheimer's or related dementia, and you sit there and visit with the family, and you talk about things, and they'll talk about, well, it's in my family, and they just kind of leave it at that. But there are testings that can be done for cognitive impairment, and why do you think it's important to screen people for cognitive impairment even before they show any signs, when they're still mentally sharp?
Okay. Although Alzheimer's is the most common one, we still don't have great treatments. There's new things that came out in the last couple of years that are being pushed by the companies who make them and the researchers who did the research, but they're not a panacea, and they can cause side effects and problems, and they're intravenous, and they're expensive. So there's that. But I think it's important to know if you have something wrong. You know, if you know you have early Alzheimer's and you can get your affairs in order, you know, instead of when you're in crisis and you can no longer sign the papers legally to make somebody a durable power of attorney for your both medical and financial. You know,
we run into that a lot.
I'm sure you do.
We sure do.
And then the other things to look for in is other causes of memory loss.
Okay.
You know, people who are depressed have memory loss. People who have what we call vascular dementia have memory loss, that they've had little strokes, big strokes. You know, and then you want to get on top of all the risk factors for their strokes. So control their cholesterol, make sure the blood pressure is controlled. You know, make sure their diabetes is controlled, because all those things contribute to improved brain health in the long run, even for people who are starting to lose their memory.
So if you go back to those screenings and exams that we talked about, those are important markers to see if they might be at risk for potential dementia.
I mean, the FDA approved a test last week or the week before for a blood test for Alzheimer's.
Oh, really?
Yeah, they're measuring tau protein in the blood now.
Okay.
Instead of having to do a spinal tap or instead of having to do a PET scan. So
is that already being rolled out then? Since
I haven't seen what the availability is, but
that's fascinating.
So it's going to help tell. He does have, that is Alzheimer's, but then again, what do we do about it?
Yeah, exactly.
I think that the technology or the drugs are going to get better and better and better. You know, 30 years ago I said we're going to have Alzheimer's cure in 10 years.
I know. And I'm asking, it's important to me because, you know, my grandpa passed away and my uncle and my mom, you know, passed away. It's on that side of the family. And I could just easily say, well, it runs in my family and I might get it. But it's nice to know if there's some markers along the way that I could say, okay, it's most likely I'm going to have that. Do
you really want to know?
Well, that's the other thing. I think the only reason I'd want to know is to prepare my family and make sure, like you said, all the advance directives are in order, decisions have been made and formalized and signed off on. So I think that's
all those things that people should be doing anyways.
Should be doing anyway. Yes. Get your advance directives in order. That's the thing. Go ahead.
Let me go. The other reason it's important is because there are a couple kinds of reversible causes of memory loss.
Okay.
You know, people have normal pressure hydrocephalus, which is a buildup of fluid in the ventricles in the brain, and that is treatable and that's what Billy Joel has right now.
Oh, is that what it is?
Yeah,
okay.
and you put if you can prove that they have it and prove that it improves when you do a spinal tap, you can put a shunt in from the brain into the abdomen to drain the fluid, and that reverses their memory problems.
Oh my gosh! But that's a specific.
That's a specific one. Yeah. Okay. And then if you have, you're growing a brain tumor, benign or malignant, you find that and you can take that out. Or if you've had a fall and you didn't know it, but you have a subdural hematoma that's compressing on your brain, fix that. So you've got to rule out the fixable things.
Do you see that going back to fall risks and things? Do people come in from falls and they don't realize they might have done more damage in bumping their head than they might have just thought, well, I just bumped my head. But there might be a subdural hematoma or something like that going on in there.
Especially if they're on blood thinners, which about half of people seem to be lately.
Yeah. And if you do that, what's the response in saying, okay, you had a fall, you didn't just bump your head, there's some more going on? What would you...
Well, I asked them, I said, did you go to the emergency room when you fell?
Okay, all right.
Because the emergency room would have done a brain scan.
Yeah.
And they say no. And I said, well, how are you feeling? Not great. Well, let's get a brain scan.
So get a brain scan, okay. So I wanted to go also to immunizations. What are probably the top immunizations? I know we talk a lot in healthcare about flu and pneumonia. Shingles is, getting to be a worse thing with seniors.
Yeah.
What are those kind of the top immunizations, or are there others?
I think everybody should have a flu shot unless they've had a bad reaction to it. I think everybody ought to have the pneumonia vaccines, and they keep coming out with new upgrades on them every few years, it seems. So those are important. And recently they come up with the RSV vaccine, and I think that's important, but that's especially true for babies and old people.
Okay.
And by old people, I mean 80, 85 and above.
Okay.
Unless you're younger and you have other conditions that make you at risk.
Yeah. Okay.
So, but, and then, shingles vaccine is good, and, shingles doesn't kill you, but it's pretty uncomfortable.
I've heard it's pretty painful.
Yeah.
Yeah. Okay. Well, one thing I wanted to say is thank you for all this, but one question I wanted to ask is, in closing, where do you find the most fulfillment, or how do you, when do you feel the most fulfilled in practicing medicine?
Let's see. If I find a problem that can be fixed and refer them to the right place to get it fixed, and they then go on to have less morbidity and not die of it.
Yeah.
If I find that they come in to see me and I say you really need to get a colonoscopy, they get a colonoscopy and they find their colon cancer because they never had a colonoscopy, that's a win.
Yeah.
Plus, I develop good relationships with lots of my patients, and
I was going to ask you.
I had a lady today. She says, "I really appreciate you."
That's good to hear.
Yeah,
and they do appreciate you.
that is good. That's fun.
Do you? This kind of goes back. I wasn't planning on asking this, but with the telehealth and everything, do you prefer people coming in and seeing you rather than the telehealth? Does it help?
Well, yeah, that's always better to be able to actually touch them.
Seem a little more relational. And,
yeah, but if they're debilitated, if they can't make it in, or if they've got a really bad respiratory infection, I don't want them coughing all over me in the office. Yeah,
that's true. Well, Dr. Humbarger, I appreciate it so much, taking the time and participating and contributing to our integrity in healthcare. And I'll just ask you this: is there anything that you'd like to share with us in closing?
Well, I'd like to give some props to the American Geriatric Society and this website they have called healthinaging.org.
Healthinaging.
Healthinaging.org.
Healthinaging.org.
Yeah, and all about geriatrics and care, and actually how you can find a geriatrician, and they talk about vaccines and age-friendly health care and all that. One of the big things that's being promulgated by the AGS and geriatricians is what they call it the either 4 or 5 M's of geriatrics.
Okay.
And this is their tip sheet that I got from there, but I saw this at a conference recently too.
All right.
And they talk about the 5 M's are mind, meaning your mental activity, mobility, because lack of mobility is what drives a lot of people to assisted living.
That's true.
Medications, and we're committed as geriatricians to reducing what we call polypharmacy, which is having people on too many medications, inappropriate medications for their age. They want to take a sleeping pill, and I say, well, if you take a sleeping pill, you'll wake up in the middle of the night to go to the bathroom and fall and break your hip. Yeah. So multiple complexity, and then the one that really is, I think, matters most is called matters most, and that is, what matters most to the patient. Is it controlling their diabetes really closely, or making sure that they don't get hypoglycemic? Is it keeping them alive at all costs, or is it allowing them to have some comfort while all their grandchildren come to visit them for the last time? I
like that. What matters most.
Yeah.
Okay. Thank you for that. Yeah. And it's, again, the website is
healthinaging.org.
Healthinaging.org.
You can have that.
Thank you. Well, thanks, Dr. Humbarger.
You're
appreciate
welcome.
it. And we'll be in touch soon.
Good to see you, Charles.
All right. Thanks.
Yeah.